Yes, sir, we are live now. Please join video, sir.
Yes, please. Good evening to all. This is Chandra Mohan, orthopedic and sports physiotherapist from Sri Samraj Physiotherapy Center. A warm welcome to all the participants from India and abroad, and Fitness and Rehab India YouTube channel viewers for the ExRxIndia and Sri Samraj Health Services Private Limited's presenting Webinar Super League. We are moving towards a world record. Today's session, this session is 102nd in association with Sri Samraj Physiotherapy Center, Fecal Studio Chennai, PhysioActive Gurugram, Sairam Academy Chennai, Dusat Creations West Bengal. Powered by Fitness and Rehab India YouTube channel. Today's topic is role of physiotherapy after renal transplantation. Will be presented by Dr. T. SENTHIL KUMAR MPT Cardiopulmonary Science, PhD, Associate Professor, Sri Ramachandra, Faculty of Physiotherapy, Sri Ramachandra Institute of Higher Education and Research Center. I welcome ExRx India team members, Professor Duna, Rupesh, and I welcome other participants, and I welcome now Dr. T. SENTHIL Kumar and request him to start the session now. Please, sir.
Yes. Thank you, Chandra Mohan sir. Okay, at the outset, I wish to extend my sincere thanks to the excellent job done by ExRx, Chandra Mohan, Dr. Rupesh, and Dr. Duna ma'am. Okay, so this session basically it was the inspiration that started as a part of the clinical work. Okay, this particular topic got me an interest because this is the one area where we are exploring. And as physiotherapists, okay, we have an extended role in different parts of activity, and renal rehabilitation is one of the developing area where we have a lot of things to be done. Okay, so with my warm regards to the organizers and my acknowledgement to the management of Sri Ramachandra Institute of Higher Education and Research, deemed to be university, I will start with today's session. We will move on to the topic. I hope my screen is visible, sir.
Sir, please go to full screen. Yes, it is visible, sir. Please continue.
Yes, and as today's topic, we are going into the topic that is role of physiotherapy after renal transplantation. So as I mentioned, this is one of the important area where we are expanding our horizon of activity. To start with, we have to understand the basic why this renal transplantation is important. So all of us come across this particular terminology, CKD, chronic kidney disease. So chronic kidney disease is considered as one of the upcoming epidemic or non-communicable disease which needs to be addressed. As we can see that in a global scenario, we can see the incidence and prevalence of this particular problem, chronic kidney disease, is in a steep increase. So every year, the number of people who are getting affected on the kidney functions or keep on increasing. There are several factors. One of the important factor is the diabetes. The second thing is your changing lifestyle. As people are entering into the modern era of communication, transportation, we know that the physical activity level and there is lack of lot of exercise. Okay, so when there is a lack of exercise and physical activity level is modified, as well as there's a reduction in the nutritional intake, improper nutrition. So this is going to lead to a lot of metabolic disorder, which includes diabetes. So in the diabetes is one of the commonest cause. So as you can see here, for this chronic kidney disease, which is the reason, which as it progresses, it goes to the condition of renal failure. That's where we are required to go for the renal transplantation. So across the world, okay, we can see that the death rate due to CKD is quite alarming. Okay, so one of the definite treatment that we'll be discussing is renal transplantation. So renal transplantation from the medical aspect or the surgical aspect, it is considered as one of the standard therapy for a end-stage renal disease. To start with, we have to understand the causes. Among the various causes, we have seen that the diabetes is one of the leading cause for kidney disease. The next one is the hypertension. In these issues are going to increase in the modern era, and that is the reason why we are going to have increased case of sick kidney. So as it is becoming an epidemic occurring in every places according to the changing lifestyle, the number of people who go for a final stage of renal failure is on a steep increase, and that makes it necessary that we have to have a proper management of these patients. So coming to the management briefly, so we are not going to the detail, but to know the normal renal replacement therapies that is administered in a chronic kidney disease patient. So most of the drug-induced or burns patient also have acute renal failure, but they do recover. But here we are referring to the chronic renal conditions, which are usually managed by conditions like nephritis, glomerulonephritis. So when it is crossing a particular GFR limit, a lower GFR rate every day, it is going to low for a increasing the severity of the condition. So in that case, the patient goes to the need for hemodialysis. So the regular hemodialysis is required for most of the patients, and we know that this hemodialysis or a peritoneal dialysis that helps to serve as a temporary remedy, and it can be managed to mild to moderate category. But as we know that as the renal condition is worsening, it goes to the state of a end-stage renal disease. There, in case the kidney transplantation is the final solution. So ultimately, at one point of time, all of these patients are in need for a transplantation or a new organ replacement. So when we are talking about the new organ replacement, that becomes a matter of life and death. Okay, so we know that many people are requiring the transplantation, especially kidney transplantation is required. And according to the one of the leading study, it has been identified that the Western countries are wide ahead in getting the decided renal transplantation. Okay, we have a lot of people who are coming forward. The awareness of organ transplantation is increasing. Okay, that's what this particular graph is showing you. So you can see that the countries like Spain and United States are quite ahead in getting the decided donor organs, whereas the living donor organ is very less in these countries. Why I'm particularly interested in this particular data is it's quite contrast to our country. Okay, that we will discuss. So here you can remember throughout the world, okay, the decided donor is the highest in prevalence or percentage. Okay, coming to the transplantation as a whole. Okay, so we have two basic types. That's called decided donor renal transplantation and live related renal transplantation. So this decided donor renal transplantation, as we said, the organs are harvested from the cadavers. So the cadaveric donors become the source for this decided donor transplantation. And we have a lot of procedures like the maintenance of registry to get a particular organ at a particular time. Okay, so this registry is following a legal proceeding. Okay, so how the allocation of organ should go. Okay, so to say in reality, in India for past 15-20 years, so these proceedings, which was very toughened, was slowly relaxed and made modified versions, and this is made more applicable or more approachable for the population. So this has ensured that so organs are getting delayed without any delay. That's an important aspect in overall success of the treatment. Okay, and in spite of the fact in India, the decided donor transplantation, even though it is happening, but usually since the number of people requiring the organ is more, so the long waiting periods are seen. So as the waiting period is more, as well as even if you get an organ, once they are transplanted, okay, so they are showing generally a low success rate. This is because most of the time the organ has to be procured and it has to be properly stored, and if needed it has to be transported, and these things consumes some of the lifespan of the particular organ, the kidney which is being harvested from the cadaver. Okay, so apart from the legal proceedings, acceptance by people and awareness, These logistic reasons delay the success of delayed decided donor transplantation. The otherwise around, as I said, in India, we entirely depend upon nearly more than 80% of kidney transplant in India is due to volunteer donors, and that is usually a living people, usually a mother, father, or spouse. And several of these aspects have been of interest because whenever it is observed, okay, the donor organ, if it comes from the mother or a female spouse, the success rate is more. Okay, so in a lot of time, many interesting studies have been done, and finally they have identified that the genetic relationship between the mother and the child is very strong, as we all know, and it is proved that that particular organ transplantation goes in a long way, and the lifespan and the expectancy of quality of life is good when the particular organ gets from the mother. So this is an important data that we have to remember when you handle the patients. Apart from that, it can be from any other family member, but only thing is they should be legally having an established relationship. And even today, there are some legislative changes or adaptation or flexibilities are available, wherein the other members of the family or distant relative are also allowed to do. But this is undergoing a stringent committee is there, so it has to pass through it. So these are the various proceedings which is required, because otherwise, okay, the one more danger in a transplantation medical affair is people are alleging that it should not become like a business. Okay, for a meantime, it became like a business. Like people were even targeted to get an organ. Okay, so that's why the legislation were made strong, and it's very important that these steps are followed for any institution to get an approval. So conducting a renal transplantation center is undergoes, it needs a lot of legal proceedings, and being a team member, even though we are not directly related with these legal aspects, we should be aware about those things. Okay, and one of the good thing is the live related renal transplantation have a high success rate. So this we can practically see when we come across with the management of our patients with the terms of exercises. Okay, whenever we approach a patient when they are with a live renal transplantation, live related renal transplantation, so usually their success rate is good, their compliance is good, because there are many reasons. One reason is they directly see they have an emotional attachment to the people whom they are receiving, and they want to preserve that organ function. So the patient effort and cooperation is usually high, and the outcome is also better, because here we don't have that ischemic time or transportation delay. And because of this reason, and another important thing, there's a possibility to have a planned procedure, which we will discuss in detail in our management aspect. This planning of procedure or a planned procedure always have superior outcomes when it is going down an emergency procedure. So this is again one of the important criteria that we have to consider when we approach to our patients. So coming to the success and challenges. So we have seen that for a chronic kidney disease, renal transplantation is one of the defined or established treatment, which is like a rebirth for the patient. Okay, being said that, we have a increased number of success rate, and the number of successful transplantation is keeps on increasing. So it was only in hundreds, now in latest 2019, okay, consensus registry statement tells it around we are able to perform more than 3,500 successful renal transplantation. Okay, so it is quite doubling or more than doubling because of improved surgical skills, better method of organ preservation. So apart from that, another interesting thing which we can see in this down graph, that is, we can see that the decided donor, which is indicated by the red graph, and the live donor is indicated by the red color one. So we can see that the expectancy of the graft function is better with live donor. And a very striking thing that I want you to note, all of us should note down here, is beyond one and first year and the second year, we can see that there is a drastic drop in the survival rate. Okay, and there are a lot of interesting studies, a large group of trials of studies done in Western population to analyze what are the possible reasons why after the first year and the second year there's a drastic drop. Okay, so it is found out that in most of the cases, nearly to say 80 to 90% of cases, the graft is functioning. This is a very striking feature that we have to understand. The graft, the renal graft is still functioning, but the patient dies. Why? It's because the patient is not maintaining the other physical aspects of the body. This is an important point why physiotherapy becomes very important. So to mean to say, it's not only physiotherapy and exercise, it's a whole rehabilitation. But one of the leftover area or the gray area we can say is the physiotherapy aspect. That's why it's an important area I want to focus. Okay, so we can flatten this curve. Instead of dropping, we can extend the lifespan, because it has to be noted that, as I mentioned, more than 80% of people die with a functioning graft. That is because the kidney is working, but still the person is dying. That means there is other components which can help the people or which is not maintained, which also includes your physiotherapy or exercises. And on the other extreme, we can see that there's a very gross organ shortage. Why I'm telling this? Because we have that social responsibility, because we know that so much of people are waiting. More than 150,000 people every year, they need a transplantation. But we are able to do it only for 3,000 or 5,000 at the maximum presently, in spite of having increasing awareness. So we can be proudly saying that India is improving a lot, and especially in India, after India has said, Tamil Nadu is leading in number of organ donations. Okay, so there are social and other things, and it is because of the awareness of people, and throughout India it is increasing. In spite of that, we can see that more than 1 lakh people are going without organ availability. They are suffering. So in that case, we should not lose the patient within 2 years with a functioning graft. So that's why it becomes important that we have to extend the lifespan along with the quality of life, where physiotherapy has a vital role. That is the main point I want to emphasize in this presentation. So as a general background of this particular data that we are going to see, okay, it is the various literature have shown that there is an increase in survival rate and the quality of life comparable to dialysis, because the dialysis is the only available thing, even that is not available to all of, like a developing country like India. Okay, so in that case, in spite of doing dialysis, people cannot survive beyond 10 or 15 years. They cannot manage. Okay, so when the kidney transplantation becomes a definite cure, so then it is our responsibility as a team member to sustain the life and the quality of the patient. So that has to be emphasized and educated to the patient and family. As I mentioned before, the cardiovascular disease becomes or remains the primary cause of death for renal transplant recipient. So we can understand. So why I was interested, being having cardiopulmonary background, it was quite striking for me. So this particular population, we are not much focusing. Practically, that's true. Okay, so that I will explain it further. And this cardiovascular disease, which can be prevented or at least postponed. Death is inevitable, we know that, but we can postpone so that the patient have a decent quality of life. Just having 1 year, 2 years after a transplantation is not a big deal. It should be nearly at least 25 years or 30 years. So that is the good purpose where we have an important role that we have to understand. Okay, so the other related things are, we can see that people become obese, they develop sedentariness. The sarcopenia, that is the muscle protein loss, is a potential risk factor after transplantation. And this particular change that is usually attributed because of the various aspects like diet, their physical activity level, so which we will see again in detail. But we can see that there is on the other extreme, we are getting a good amount of data from Western studies that the patient's potential benefits are possible if they do a proper exercise. So it is very disheartening to know that in spite of having so much of evidence that exercises could help our people if it is properly performed and sustained for a period of time, but still we are losing so many people with a functional graft. So again, we are emphasizing that we have to have a proper understanding so that we can provide best of our abilities to our patients. So the cardiovascular thing in a kidney patients or after transplantation is a primary leading cause, and there are a lot of literatures which are saying that there is innumerable reasons, but we are finding out how we can prevent it. Okay, the functional graft death can be prevented if you can prevent cardiovascular death. The traditional risk factors have been described like obesity, okay, increasing level of cholesterol, okay, all those things are there. Apart from that, what is quite interesting is there are non-traditional risk factors like hyperhomocystinemia, increasing CRP level, and interleukin 6. So this is one of the, we can say it's a breakthrough, even though it is more than 15 years. Still, we have not fully control of these non-traditional factors, and still they are evolving. One of the important way by which these non-traditional risk factors, including the traditional risk factors, can be reduced is the exercise with a good diet. So again, we have an important role. The cerebrovascular disease, which is again could be a vascular disease, because we have studied that CVA is a focal neurological deficit lasting more than 24 hours, mostly of vascular origin. So again, the blood supply becomes important, and that blood supply have all the chances to go for an obstruction in a higher amount after renal transplantation. So the risk factors that we are seeing after renal transplantation, which can lead to renal failure, as well as which can be developing after renal transplantation, include hypertension, diabetes, dyslipidemia. So dyslipidemia means it is not only a high level of your LDL, total cholesterol, it is also low level of HDL. So we all know that low level of HDL has equal or even more risk than having a high level of total cholesterol. It depends upon. Okay, so HDL reduction is also important reason your breathing to get obstructed or your vessels to get damaged. The obesity is another risk which can develop. The reduced physical activity, osteoporosis, which is one of the neglected area. So very often when you say that osteoporosis is happening, okay, so we refer that the patient is because of only restricted activity. It is not only restricted activity, the nature of activity, the loading of skeletal system is very important. So again, our exercises and physiotherapy, the way of exercises that we are going to give becomes very important. The last thing but not least, the sarcopenia, the muscle weakness and the fatigability, which is profound in a chronic disease patient, chronic kidney disease patient. And it is very surprising, after 1 year or 1.5 years of transplantation, people gradually develop these similar problems if they are not properly used. I think we all know that our body follows a simple principle called use it or lose it. Okay, so whatever it may be, the muscle or a nervous system, when we are not properly utilizing it, they will degenerate. Okay, same way the sarcopenia said to happen even after a successful renal transplantation. Okay, so I think to make it short, I think already we discussed the problems. In terms of duration, the immediate or short-term problems are diabetes, hypertension, and there could be some cases with acute renal failure where we have to be a little careful, and this is one of the precautions we have to take in the post-operative period. Hypertrichosis, this is a simple thing where you have excess hair growth, and gingival hyperplasia, which can affect the intake ability of the patient. So these things should be also addressed. The important thing is the long-term problem where there is a new onset diabetes. It is said that nearly 40 to 50% of people minimum in Indian statistics, it is around 60%. Okay, they develop diabetes after transplantation. It's very pathetic, no? Because after doing one procedure for a better survival, the patient develops another problem, and this is mostly attributed to the physical inactivity, diet. In fact, the drug interaction is also said, but drugs, we have to understand, they are required for the patient to sustain the kidney function, to accept the kidney. Okay, so we have to see the other ways how we can help the patient so that they can prevent it. Okay, definitely there are newer drugs coming up and their survival and the complications are getting reduced. But as we introduce one chemical into the body, we get another risk. Okay, so they are taken care. So from our side, exercises has a vital role where we can prevent these issues, obesity, and as I said, important thing, the cardiovascular risk. The another emerging trend is the malignancy. It is said that nearly more than 15 to 25% of people die because of cancer developing after renal transplantation. And again, it's attributed to the physical activity and the exercise level is reduced. Okay, the final thing, the psychosocial changes. as a human being, because we are not machines. So as a human being, we should have a better interaction ability, and the social skills of the people should be restored. Otherwise, they will not mingle with the society. That's why, again, most of them, when the people, if you see why they are not going for the social gathering, the important reason will be lack of physical abilities. So in all the aspects, physiotherapists, we play a vital role, and we have to learn how to do it effectively. And that is the purpose of today's presentation. Okay. So being said that, in Indian scenario, because as I said, in Western literature, we are having ample of evidences to say that people can grow to a higher level. They can be trained to a higher level. And there are something called Paralympics. Okay. Similarly, Olympic Games, where people with chronic disabilities, including renal transplantation, cardiac transplantation, they participate in Western community. That means people after 60, 65 years with the renal transplantation, they are participating in competitive events. But in India, sadly, that particular need is not there, or the interest is not there, or the awareness is not there. That is what mainly lags. Okay, as we see here, in the global scenario, we have a good awareness among the people. We have an established rehab setup. These two are yet lagging in India. So the awareness is still not there. Okay. So I'm not talking about only immediate post-operative thing. Okay, that you can understand my end of the session. I'm not only talking about the immediate post-op care. So I'm talking beyond it. Okay. It is not established in India. Sophisticated equipment is not there. So we cannot do the same thing what Western people are doing. So we have to see how we can do in an effective manner with whatever facilities available in our country, what our population can afford. Okay, definitely you have treadmill, polar, everything is there, but whether all those things are possible, maybe the supervised setup is fine, but what about the people who are going back? So people are coming from villages, towns to get operated. So we should have a proper follow-up system, and also the insurance coverage. So these things are also again well developed in the Western population, and in India again it's sadly lacking. And another important thing, very pathetic thing is, we are trying to adapt the Western lifestyle. So whatever the Western people do, we want to do, but we don't take up all the good things. Okay, so the lifestyle includes in the food. Okay, and has the comfort of convenience, transportation, everything is improving. And one way it's good for us, the other way that is reducing our physical activity level. So naturally we are losing, or we are becoming more and more sedentary. So these are the various reasons why we have to address this problem in India, and it's very important. Okay, so as I mentioned, these are the various problems that needs to be addressed. Hypertension, which can be a persisting one or a new hypertension, new onset diabetes mellitus, which happens after transplantation, obesity, less physical activity, osteoporosis, changes in the bone density, sarcopenia, the muscle weakness and fatigue. And main thing I want to focus is the increased cardiovascular risk, which is not immediately happening, but it happens within 2 to 5 years. Slowly the risk is increasing, and psychosocial changes. And this already we have discussed. Just to summarize, the various aspects which is contributing, no, the need for exercise-based rehabilitation. I think now in India, per se, the medical management and the surgical management after the transplantation is in a good pace. Okay, even exercise training in the immediate post-operative period, yes, we have doing good job. But the thing is whether we are able to carry over the effects of the benefits of initial benefits or initial care. Okay, because there is going to be a long-term drug interaction, there's going to be immunosuppressors and steroids. This will make the patient to have increased food intake. On the other hand, there is a lack of awareness and rehab setup. And importantly, what I say is the follow-up system. So I think we have to work upon the follow-up system, especially for these transplant people who needs supervised sessions at least once in a while after the period of 3 to 6 months after a successful transplantation. And pre-existing diseases like diabetes, hypertension is very common. As I said before, nearly 80% of people have these issues, which can get worse. So this you can see that this becomes a vicious cycle. And the last thing, especially in India, is the fear of the post-surgical complications and the nature of social support. Okay, we cannot blame our family members because they are always supportive to our patients. Okay, so they don't want our patients to get struggled. They give full support, but sometimes this overprotection becomes the problem. Okay, they say only you go to job and come back, that's enough. Okay, so this is what we come get the feedback from most of the patients. Why you're not going for progressive exercises? You're just going for 1 or 2 small short duration of walk, because they say that beyond that, if I go, something might happen. This is again lack of awareness, and the extended support or overprotection created by our family support system is also becoming a problem for our patients. So this needs to be addressed. This is where our education about the problems to the patients is very important. Coming to the physiotherapy part, the pre-operative and post-operative therapy are two possible things. And pre-operative renal transplantation, our physiotherapy can be introduced if it is going to be a planned surgery. As I said before, no, the live related renal transplantation. So in that case, it is be happening effectively. We can have a planned pre-operative sessions, pre-operative morbidity whenever it is present. At that time, the patients are referred to us, and people having pre-operative chest complications. So in order to resolve it, we are referred. And people having extreme reduced effort tolerance, they need a pre-operative therapy, and they do get a reference. And we can have a good setting of goals, because we can plan what should be the post-operative level that could be achieved in these patients. Mainly, we can prevent the chest complication in the early period of the post-operative time. But this is not always possible, because it is possible only in a live related donor transplantation, whereas post-operative treatment is possible for all the patients. Okay, it could be live, or it could be for the deceased donor. So many times we also get deceased donor transplantation, but remember, as I said, live related transplantation is most common. So if you have a good awareness in your team, rehabilitation team, okay, so even though they need not get admitted, when they come for a pre-operative workup, physiotherapy should also be initiated. Okay, but some of the cases where majority coming patients with the cadaveric transplantation, okay, with the increasing organ donation capacity in developing country. Okay, so here only post-operative care can be given, and we have to understand, once they come to the post-operative phase, it becomes something called as a dynamic evaluation. The patient's conditions changes every day, or every session it needs a proper evaluation and understanding. So as you do an evaluation, the goal setting varies according to the clinical scenario, and primarily we have to manage on the stabilization of the patient, okay, initial period, and then we talk about exercise progression. So stabilization period, yes, it is done under the hospital care, but what happens about the exercise progression? That's where there is some slackness. And importantly, as I want to say, the risk factor reduction, which usually considered as one of the aspects, no, after cardiac surgeries, no, it's well addressed. Whereas it is not happening in case of a renal transplantation, where again you can see that the cardiovascular problem, the physical incapacitation is a major thing. So this is again a point that I want to emphasize. The risk factor reduction should also be set as a goal, long-term goal, before the patient getting discharged, and that should be planned. That's how we are going to see. The challenges that we see across in our structures, in our hospital setup, is usually we have an unstructured care or routine care. We say, wherever you go to physiotherapists, when we ask what we do for your patient, when you will make them walk, whenever it is possible, once the vitals are becoming stable. So how much exercises you can give? I think there is no fixed structure. I'm not saying that repetition, everything can be defined same way for all the patients. No, it's not possible. But how it should be progressed, whether it is getting really progressed, and whether it is getting monitored. No, it is not possible. To my knowledge, it is not happening in most of the places. Definitely, immediate post-op care is happening, but beyond that, the structured care is limited. The phases of training is not established. So already we would have studied, no? In cardiac rehab, we have phase 1 training, phase 2, and phase 3. A similar protocol or the similar principles of training is possible in renal transplantation, or it is required, but it is not still established. An important thing, the follow-up care is missing. Okay, we don't know. Maybe we are seeing the patient for chest clearance. We make the patient to walk, okay, and we think the story finishes there in most of the cases. But actually, there only our story begins. Okay, that's what we have to emphasize. Okay, and multiple comorbidities are present. So we need to address all of these issues when you want to manage our patient. And exercise progression is not in pace with clinical progression. This is another important point. So whenever the kidney functions are struggling, we try to give more exercise. The early period, no. So in the immediate post-op period before discharge, we want to make the patient to stand, walk, do a stair climbing. We have to understand that is the time the kidney is recovering, whether deceased donor or a live donor. So it's recovering. Yes, fine. You have to give exercise support. But after the kidney has recovered, after 3 weeks, after 6 weeks, okay, after 3 months, what happens? It's a question, big question mark. Okay, so we don't have an answer for it. Okay, so that's why I'm saying the exercise progression is not in pace with the clinical progression of the condition. Okay, and most of the time it happens so that it is only by the self-directed exercises. The physician, to their knowledge, they prescribe the patient. They ask the patient to be physically active. Okay, but you have to understand, just being a physically active and doing a structured training program, both are not equal. We all know that. But if you don't do that, the optimization, that is the important principle of exercise training, that is not achieved. Either the patient will go for overtraining or they will go for an underloading. So both are not good. Okay, so we have to, as physiotherapists, we have to take the responsibility to continue the care to our patients. That's called continuity of care. So I'm going to talk about a structured training program which has been tested, and this has been validated, this has been applied, and this is adapted from standard guidelines. Okay, so it is putting together of all the possible exercise abilities to what extent we can improve. Definitely, this needs to be changed according to the patient condition. It needs to modify, but this is going to give you an overview how we can progressively go for training of our patient so that our patients will get optimum benefit, and importantly, the long-term complications can be minimized or rather prevented. Okay. So moving on ahead, so I'll just divide it. So we know that these are all hypothetical phases. Okay, the phases are phase 1, phase 2, phase 3, like as in cardiac rehab. So these are all hypothetical divisions, but the main thing is we have to understand the principles here. That's what I want to say. So for remembering, we may have phase 1, phase 2, phase 3 terminologies, but it is not fixed. That we have to understand. This is based on the principles of training. Generally, phase 1 we refer immediate post-op period till the patient gets discharged, and phase 2 is post-discharge care, where there's a progressive training happening, which can last somewhere from 3 months to 6 months, depending upon the nature of the hospital setup. And phase 3 could be beyond 6 months. Okay, so this is for the understanding of our principles, how we can progress. Okay, so if it's clear, as I mentioned, in the immediate post-op period. So I'm not going in for a routine evaluation setup, but I'm going to focus on the specific evaluation being a special population. We all know that we'll be going through the case sheet. First thing is you have to identify the patient, okay, and you have to establish what is the surgery done, what were the indications of the surgery, okay, and what is the duration, effect of anesthesia, how long the patient was on ventilator care, and when the patient was weaned out. And we will have to leave for the PEG analysis, that is a post-extubation gas analysis. The first ABG taken after extubation, 2 to 3 hours, and what it shows, what is the general progress of the patient, vitals. Okay, so I'm just showing you here what are the vital parameters which is specifically important we have to concentrate, okay, in a post-transplantation patient. So I have listed down here, just shown a sample where we can see that the heart rate, the systolic BP, diastolic BP, the respiratory rate, and SpO2. We all know that this is the basic vitals. The important thing is this particular changes which is happening before an exercise session and after an exercise session has to be monitored at least for 3 days. Okay, at least for one session, the first session of the day. Okay, if ideally it has to be done for every session, at least for 2 to 3 days. Okay, and at least for one session after that, because this changes in the response. I'll tell you how it is very important, and this can induce a lot of small important changes in the patient, starting from their physical ability, the physiological change, the psychological support. This will definitely transform the way the patient perceives or accepts the physiotherapy. Okay, if they know that they are getting monitored, they get the full confidence to cooperate. Apart from that, renal function like burn creatinine and especially the albumin levels has to be noted, and total protein for our overall view about the whether patient is going for any excess proteinuria, we have to identify. Bicarbonate and HB, especially the hemoglobin, is very, very important, especially in the preoperative status itself. The HB is one of the important factors because we all aware about that. We have heard of the term called renal anemia. Kidney has a vital role in controlling the erythropoiesis. So whenever there is a renal failure, obviously those people will have a renal anemia, okay, kidney induced anemia, and this has to be as a physiotherapist because we need to exercise the patient. It has to be addressed and it has to be noted. And I will also address about the other musculoskeletal aspects what we have to talk about. So coming to the specific physiotherapy assessment, I will take few points to be in detail to be noted. The first thing is the referral basis. Okay, so we all know that whenever, as soon as we get a patient with a referral card, like physiotherapy is required. Okay, and many a times, no, it is refer like this patient after a transplantation. Okay, a history of diabetes is there. Continue with physiotherapy. Okay, so we may not have much details, but we have to identify what is the need, in what stage the patient is being referred. Is it for the chest complication? Is it for the limb mobility or ambulation and general mobility, or it is for flexibility also, or is it for a postural hypotension? Okay, and we have to consider all the things together. Okay, so the indications why the patient has undergone a transplant and what is the present need for physiotherapy. So this has to be apart from only chest care, we have to think beyond it, associating all the comorbidities. The vital stability is important to start with our physiotherapy. Okay, so heart rate. So the important thing about heart rate here is the heart rate and systolic BP is usually taken combinedly, especially for renal transplantation. One important thing is most of the patients with renal transplantation, they suffer from diabetes. Nearly 70 to 85% of people do have diabetes. Whatever may be the age group, we have even early onset diabetes. And they suffer the condition for at least 5 to 10 years before they get an organ. Okay, but nowadays we see some young people within 2 to 3 years they're getting operated, well and good. But most of the cases they suffer from diabetes and other comorbidities, minimum 5 to 10 years, and it is severe. And by that time, we have know that autonomic dysfunction is very common in CKD patients. Apart from electrolyte imbalance, they also have autonomic dysfunction, and this will affect the cardiac function very much. So this is what we have to clearly understand. So heart rate and systolic BP, rather than seeing them as an individual entity, apart from that, you have to always go for a RPP, rate pressure product, the product of heart rate and systolic BP, which is an indication of the cardiac load. We know that, and that has to be mainly kept in your memory. That should be analyzed whenever you think about exercise training for the patient. The next important thing is MAP, the mean arterial pressure, which is usually referred as 1/3 of your systolic and 2/3 of diastolic. Okay, and this mean arterial pressure reflects the tissue perfusion pressure, and especially in a patients with kidney disease, this is very, very important. The MAP is very important. Whenever the MAP values are going below 60 mmHg, you have to be very careful. And whenever it goes less than 50 mmHg, you have to wait. You have to see for the kidney functions to see that whether the patient gets proper renal perfusion. Okay, so if the patient renal perfusion has not still stabilized, then probably you can only go for a maintenance exercises, chest clearance program, passive therapy. Okay, and we have to avoid active exercises to start with, because this can cause something called acute renal injury. So this particular point we have to make a note. Okay, and another thing, corollary of this is a hypertensive response. Most of the people, again, we have seen that 70 to 90% of people have hypertensive response, even though they may not have an hypertension before. After the surgery, it may be because of the surgical stress, which is exaggerated in a kidney transplant patient, because kidney has a vital role in stabilizing, in regulating your BP. The hypertensive response is very important, so we should not be scared about it, because these people are adapted to a high level of BPs. Okay, at the same time, we have to take the precautions. That's why I said your systolic BP heart rate should be taken together. Look for the MAP, then you can see the hypertensive response, because normally a linear response is expected when you do an exercise. But in most of the transplantation patient, in the initial phase, we see a non-linear response. There's an abrupt elevation of systolic BP, a jumping of BP. But if you do exercises regularly in a rhythmic manner, we have very well seen that this hypertensive response flattens. It takes at least few weeks, but a definite response. Exercises only can make a flattened response. Otherwise, it will make the patient to stay in the hospital. It will delay the exercise capacity of an individual. The next important thing, when you go for that post-transplantation patient, see whether they have developed any pulmonary edema, which is one of the serious problem. So in that case, again, we have to go in for calculation, like whether the patient has got any problem of ARDS. Okay, we have to go for oxygen transpiration index. I think you have some previous session where you have discussed about oxygen transpiration steps. Okay, the oxygen index and your AA gradient. So those things has to be calculated to see really to what extent the physiotherapy can be given. That's an important thing, because when there is going to be a pulmonary congestion, so we have to respect it. We can give exercises, but not exercise in a progressive manner. So that's a limitation where we have to know where we have to stop. Pedal edema. When there is a pedal edema, along with that, also check whether the edema is bilateral or unilateral. Okay, so in a post-operative period, very often, and we see that people getting organ transplanted on the right side. So you can see that most of the cases, say more than 90%, the right side the organ is transplanted, and we see that because of the inflammatory accumulation product, many people, if they develop an abdominal edema, it is associated with pedal edema, or sometimes we can isolate pedal edema. That may be because of increased inflammatory process happening in the abdominal area after the surgery, the right hypochondral area. No, so behind it, where they have incision, there's increased inflammation that can compress the inferior vena cava, obstructing the blood flow. So if you have a pedal edema unilaterally, your exercises, your positioning techniques becomes very important. On the other end, the abdominal edema, we have to be careful, because excessive abdominal edema can cause damage to the kidney for first 48 to 72 hours. That's why the patients are continuously monitored for the abdominal circumference. So this is as a physiotherapist, we should also note down whether the patient is improving or deteriorating in terms of abdominal girth measurement. Okay, so if the patient is going for a progressive increase in abdominal girth, definitely that means the patient has some issues. So we have to see for the renal studies. We have to look for the RFT parameters keenly, and we have to go for a guarded exercise progression. The next important thing, the breathing rate and pattern. Generally, we are referring here to the inhibited diaphragm. So when you have a peritoneal dialysis for a long time, okay, or abdominal ascites, so definitely it will affect the diaphragm dysfunction, and the patient will start using their accessory muscles. So this has to be addressed, and we have to retrain the patient, and it is a emphasis of treatment. Okay, breathing pattern and the rate in the initial post-operative period. Suture, the drain location and their status is very, very important. As physiotherapist, okay, we have to assess whether the sutures, how is the healing status. Okay, sometimes we may have an extended suture which can come to the anterior aspect, or extend on the posterior aspect to the scapular level. So it shows how much extensively the surgery has been done, what is the healing status, and whether there is a drain tube is present for the suture drain, which will be usually for 24 to 48 hours, and how many drains are placed. Okay, especially important when you are mobilizing the patient, because some people, even after third POD, they continue to have more accumulation and the drain stays there. So the drain locations, the status of the suture healing, okay, the nature of fluid coming out, whether you have to see whether it's an exudate type of fluid or a transudate type of fluid. So normally when you have a very turbid fluid coming out, probably along with a running temperature, high temperature, you have to know that it's infected. Again, you have to have a guarded exercise program for those people. Remember, so these are the minor points which is very important, because when we don't address these two issues and go on a routine therapy for all patients, okay, Where we have to go slow, we should not go fast. Okay, so that's why it's very important to know address these issues. Okay, and obviously we have to look in for the renal parameters, burn creatinine, and especially albumin. In some places, you have the facility of doing microalbumin levels check. Okay, and these microalbumins are one of the evolving area where they have the even cardiac predictability, cardiac risk predictability of 10 years, and it has a high sensitivity, and it is one of the predictor of renal failure and also renal recovery. So microalbumin, but this is not very commonly done. If it is done, it's a very valuable thing. Mostly it is done for research purpose nowadays. It is not as a routine. And estimated GFR, okay, is one of the sensitive tool which will tell the renal function improvement. But immediate post-op period, EGFR, along with that, they may be looking for a renal biopsy report, usually done between the 1 week to 10 days time. Okay, if that report is available, that will clearly tell you. If the renal biopsy tells you the kidney has been taken up well, the renal ischemia is not there, then that's an indication for us that we can go for a progressive training. Okay, so we have to keep a watch on the progress notes of the physician or the surgeon, where the renal biopsy report is very important. Okay, that's an important indicator for the people to decide on how to progress about the exercises. And obviously, as I mentioned, renal anemia should be addressed. Okay, remember, whenever we have anemia, normally in adult population we say that less than 10, progressive exercise is not allowed. Similarly, for kidney people, less than 10, if you have, maybe you can restrict yourself for bed exercises or around the bed exercises. Only when it is more than 10, go for a progressive training, resistance training. This is mainly in the benefit of the patient, so that you can prevent any unwanted ischemic changes in any distant organ. Because we know that when you do an exercise, all the bloods are diverted to the working muscles, so that recovering graft should at any cost should not undergo any stress. So whenever the HB is above 10, probably it's advisable to go for a progressive training, resistance training. When it's less than 10, we have to restrict ourselves to the bedside exercises and avoid any progressive resistance training which the patient has not got accustomed. Okay. Apart from that, the breathing training, bronchial therapy can be continued. Nutritional status is very important. As human beings, we need food to survive, and caloric intake and output, which is usually monitored by the clinical nutrition people. The dietitian, the clinical nutrition people are doing that. But the only thing is, as physiotherapists, we should see that notes to see whether the patient is getting minimum caloric intake. Because without caloric intake, if you give enthusiastically more exercises, that you are encouraging more catabolism than anabolism, and that can again become a stress to the kidney. Okay, so like rhabdomyolysis happens in post-burns patient. Excessive exercises without getting adequate protein can make excessive breakdown of protein, and this protein can become a stress to the recovering kidney. Okay, so this we have to, and moreover, it can also release more creatinine, increase the load on the kidney. So nutritional intake should be adequate. It should be not be like a high protein diet. So they take adequate protein, adequate carbohydrate, but energy calories available should be a minimum of 1,500 to 2,000 kilocalories, depending upon the age and the weight of the person. Okay, anybody having less than 1,000 kilocalories per day, probably you cannot go for a extensive mobilization. This we have to keep in mind. And effort tolerance, so it's very important change in the immediate post-operative period. As I mentioned, most of the patient will have a hypertensive response. Effort tolerance noting down is very important. Even a simple exercises done at the bedside, how much changes it is going to induce, that makes a lot of difference. Especially you're looking for the changes in the peak heart rate, systolic BP, then mean arterial pressure. Along with that, the drop in BP whenever there is a change in posture. This is going to be a very important indicator, the change in the vitals. Apart from that, after you finish the exercises, what is the time taken for recovery? Generally, we know that within 2 to 3 minutes is an ideal recovery time. Maybe in these patients, we may wait up to 4 minutes. But if it is exceeding more than 5 minutes, definitely either the patient vitals are not allowing you to do to that level of exercise, or your exercise intensity is like a overtraining. So we have to reduce the training. So a simple observation, that's what I said. The vitals has to be observed for every sessions in the initial 3 days. This just gives us a valuable information. So, okay, it is not that during the therapy just you give one vitals and you just check. You started your therapy, you finished, and you saw okay, patient is comfortable. But it should not result in excessive fatigue, so that next day the patient will not agree the exercise. Many times it happens. So first day, second day, patient will do exercise. Third day, if you go, they'll say, no, sir, I'm very tired, I will not do. The reason was the exercise session was not properly graded. That is a successful requirement. That's why it's a specialty. So as I mentioned, the blood pressure changes. Postural hypertension is one of the important problem we have seen across many transplant patients. Especially many people may have a epidural analgesics connected to them in order to overcome that pain. And immediate post-op mobilization is sometimes asked. So you should be very careful when people are with epidural analgesics, because we know that it can induce postural hypotension. Okay, so in that case, another important thing, there are a lot of literature evidences to say that we have seen many people, like 10% of people have also shown to have some muscle weakness, especially on the right lower limb. As when we have a pedal edema, I mentioned, no, right side is very common after a kidney transplantation. The right side lower limb weakness have been noted in many cases because of sciatic nerve compression. Okay, in those people, not only sciatic nerve, femoral nerve, root level compression could happen, and that can result in a unnoticed muscle weakness. And you think the patient can stand and walk, they'll walk 2 steps, they will fall. Okay, so this is not only because of postural hypertension, it is also because of muscle weakness. So that's why I emphasize. The next important thing is the fatigue scoring. The fatigue is one of the major problem. You ask any kidney patients, I'm tired, I'm tired. They don't know what is the reason. So it is because of electrolyte imbalance, lack of protein, lack of caloric intake, anemia, several things. It's multifactorial. But ultimately, this fatigue scoring will tell us how much the patient is able to tolerate your exercise, how much you can go ahead, and how your exercises are helping. So fatigue scoring is one of the simple thing. I'll show you the chart that can be used. On RPE, whenever we do an exercise, so has most of the people are having diabetes, autonomic dysfunction has their background disease, background problem. As I mentioned, heart rate, BP alone may not serve, so you can take RPP. In addition to that, it's an objective measurement, because sometimes we cannot measure the systolic BP on movement. So RPE is one of the standardized thing, and we have identified that RPE based training program is quite safe for our immediate post-op training. Even if you want to give a resistance training or a flexibility training, okay, a progressive exercise training done along with RPE, rating of perceived exertion using a Bogue scale. You can use 6:20 scale, or you can use a ratio scale 1:10. But the only thing is we have to make the patient understand what is it. And first 2 or 3 sessions, no, you keep correlating. Whatever patient says, you measure the heart rate and see. We all know that, no, the Bogue scale from 6:20, it represents the changes in heart rate from 60 beats per minute to 200 beats per minute, which is usually considered as a highest heart rate max, okay, maximum heart rate. So that corresponds to that. So first few sessions, no, whenever you are teaching the patient for RPE, please make sure that you make a correlation and see whether the patient has really understood. Okay, so after you do that 2 or 3 sessions, you can see that the patient very well correlates. Whatever they say 7, 8, it correlates with the amount of changes. But another precaution we have to execute here is the resting heart rate could be sometimes high in these patients. So there, that has to be correspondingly equated to the Bogue scale, so that you can correlate and see. But most of the time, 90 to 95% of patients, definitely they are able to understand and tell it correctly. And as I mentioned, the other important thing is evaluation. Muscle testing is very, very important for a not only for CKD, for a kidney transplantation patient. You have to do the for key muscles. You can use a regular MMT if possible. Otherwise, do a isometric testing. Nowadays, we have an isometric devices, okay, where you can check the isometric muscle strength. Okay, so you can use a hand gripper, or you can have a custom-made devices, okay, which can be used for checking the muscle force produced for biceps, triceps, shoulder abductors, okay, your quadriceps, plantar flexors, okay, if possible for hamstrings, hip extensors, hip abductors. So these are all called as a key muscles. So when you check these isometric strength of these muscles, this becomes very valuable, and this is very important for training. Once you check this, and then you go ahead, definitely you can give the best to the patient. The next thing is abdominal circumference. So it is for the immediate post-op, as well as I'm talking about later on, where abdominal circumference has to be identified, not in case of a fluid overload status. Beyond the recovery time, beyond the 3 weeks or 6 weeks, the abdominal circumference, we know that it very well correlates with the cardiac risk. So that has to be checked. Skin fold measurements of arm, thigh, and waist, accumulated skin fold measurements indices is always good, and repeating it for every 3 to 4 weeks time is good. Functional assessment. So basically, we know that organ transplantation patient immediately cannot go for a progressive exercise testing. So 6-minute walk test is an acceptable test, and it is said that we want to achieve at least 240 meters before discharge. So even though I know it's a very low value, even this achievement is a great deal for our patients. It again depends upon various other factors. What was their pre-operative physical activity or exercise level? Okay, but at least 240 meters on a mean we have to achieve. And in some centers, they are doing DEXA scan where you can identify the bone density and the muscle mass if available. It's well and good. And again, to my knowledge, in many places it is done only for the research purpose. Okay, because it's cost effective. It is going to load the cost on the patient. And lipid profile is possible, and especially lipid profile monitoring becomes important after 3 months, 6 months, 1 year, and 2 years. Periodic lipid profiling is very important. Okay, that's where these people can be prevented from going to a cardiologist. Okay, so the lipid profiling is important, checking immediate post-op, especially in the follow-up period by the physiotherapist. And as we all know that since we are talking about exercises, it's a rehab, as I said in the beginning. We should have the past history knowledge of physical activity level, the occupation, and here I want to emphasize the felt needs. Okay, this is where many times we fail. Okay, we establish some goals in our mind and we try to achieve it. We have to understand we are dealing with human beings. Okay, so every human being and every family has their own expectations. It may be realistic or unrealistic, but they have a need. So we have to ask for it. We should have a counseling session. It's not only for psychologists, even for exercises. We have to ask what is their family life pattern. Okay, so lifestyle, how it is happening. So we have to talk to them. Then only you can have a good follow. So this is what we have seen with some people where they are ready to express their felt needs. They have a good follow and they become very optimistic and they achieve the optimal goal. Okay, this is one small thing graph I want to show you where you can see that it can be used for our patients, wherein you have a point from 1 to 7. Okay, disagree is 1 and agree is 7. So gradually what we can do is it can be used for different activities, and simple scoring on a 7-point scale will tell you any score more than 4 said that the patient is doing poor, they have extreme fatigue. Any score point of 1.5 to 1.2 change in this fatigue severity score, which is a freely available scoring system. Any improvement of 0.5 to 1.2 number points in this particular 7-point scale indicates that it's a clinically significant improvement. Okay, so any exercise program, if you want to check the validity, a simple measure we can use is the fatigue severity scoring system. We have many systems. This is one of the simple device freely available, which can be done easily for all patients. Okay, so coming now into the details about the exercise program as this. So as I said, we are going to discuss it in phase 1, phase 2, and phase 3. So phase 1, as you can see here, I have listed down for the understanding purpose the parameters what you are going to focus upon. It could be a bronchial hygiene therapy, or a limb exercises, or a mobilization and education. Under these 4 categories, I will be discussing it to make it simple. And activities is describing what you are doing to achieve it. So bronchial hygiene, we know that your breathing training, spirometer, and if needed, your chest maneuvers are used. And generally, percussions has to be applied with precaution of chest drain and suture side. And definitely, you cannot go for a normal positioning, like ideal traditional positioning. I mean, you have to go for modified position techniques to drain the secretions. And spirometer is usually encouraged to do at the rate of 600 minimum, as we all know, go up to 1200 cc per second. This is used if it is a rate-based spirometer. So nowadays we have something called volume-based spirometer, where we can start with a minimum of 500, go up to 1000 ml. Okay, so we want to achieve, the patient has to achieve at least 1000 ml to 1200 ml before discharge. And the frequency entirely depends upon the chest condition. Usually it is 3 sessions per day to start with, and gradually it can be reduced as the patient starts moving in. And the main important precaution is the breath hold should not exceed more than 3 counts. Is it a spirometer or it is a active breathing? And saturation should also be always maintained above 90%. And the BP change of 10 mmHg is usually safe limit. We know that hypertensive response is opaque. So here it is the mean change. So if you are going to give an exercises for 5 minutes, so whatever BP changes happens every minute when you are going to observe. Okay, so in the monitor you can observe it. So the mean change should not be more than 10 to 15 mmHg. The ideal thing, the minimum change should happen is 8 to 10 mmHg. Okay, and usually the breathing exercise progression is done by multiple sniffs. We know that when you do a sniff, it recruits diaphragm. As I mentioned, diaphragmatic inhibitions is very common in a renal transplantation, and because of that, they develop lung or lung consolidation. So the diaphragm facilitation using sniff technique can be used, and limb exercises we start with active assisted techniques. Okay, especially if there is an edema present, if there is a muscle inhibition present, you can use assisted or even passive movements can be given. As usual, whenever you do a movement for limbs, we have to take care that the drains, you can see the precaution, the drains and IV lines, the fistula hand, we should be careful. Usually the fistula site in the immediate postoperative we avoid. Okay, and we have to respect the pain. Okay, whenever we say that pain score in a scoring of 10, great. Whenever the pain score is more than 3, it has to be addressed. If it is more than 6 because of an exercise, usually we have to see whether we are doing any harm to the tissue. Keeping that in mind, if the pain score is 1 or 2, fine, you can continue the exercises. And another important guidelines is whenever an exercise induced pain is there, it has to disappear within 1 hour. If the patient says next session you are doing after 4 hours, that time also says the same pain is persisting, that means you have not done it correctly, you have overdone it, or the patient has done excessive or a wrong manner of performing the exercise, that you have to recheck. Okay, and progression is from a passive movements, it can be made as active assisted to active, and mobilization is done as tolerated by the patient. Usually turning the bed and supporting system is the best thing to be achieved. In the second to third POD, we try to achieve at least patient will come to sitting position. Okay, and whenever we do, we see that the heart rate is not peaking up. During mobilization, it may go up, but once you mobilize, within 2 minutes, it has to stay elevated only within 8 beats. This is a very safe limits which we can work upon. If you think it is more than that is happening, that means the patient has to be done with more warm up. Do in-bed exercises or lying exercises more. Get the heart and systems accommodated, then you make the patient come to sitting. Okay, and as frequently as you do it, it's good, and at least twice a day we have to do it. Okay, there is no exact POD where you can do this. That's why I'm just phase 1. Okay, it doesn't talk because it's not reliable to go by phase 1, day 1, day 2. Okay, so day 1 definitely we know bronchial hygiene we take care, vital responses we take care. Day 2, day 3 bedside mobilization. From day 3 onwards, post-op day 3, post-op 4, post-op 5, we have to increase around the bed mobilization, and usually by 4th or 5th POD the patient walks away from the bed. But again, these things depends upon, these are all general things we tell, but it depends upon, as we all know that it depends upon the response. So that's why I've listed the principles. As the patient improves, does better, you can go for the next higher level. That's what indicated in the progression. So especially when you do mobilization, as we are noting down the heart rate, the drop in BP, especially as I said, epidural is there, you have to note down. So education during this phase 1, the patient is gradually trained for breathing exercises, how to use this parameter, importance of splintered coughing. It's very important that you don't cause more damage by doing unsplintered coughing. So splintered coughing is important. Ankle pumps, we know. Chest physio, we have to be careful when you are applying chest physio, and take care of the drains during exercises, mobilization, and turning of the patient. So these things are preliminary to prepare the patient for a ambulation and progressive training. In the later part of phase 1, okay, so where the patient is able to achieve an unsupported or standby assisted ambulation and able to be off the monitors. So this is the phase I was telling you, between achieved in 4th to 5th POD usually, or even before that if the patient is doing well. So at that time, we have to increase the periods of independent sitting. So usually we start from 5 to 10 minutes, we can progress up to 30 minutes. And during this period of sitting, we always advise the patient, it's very important that they have to keep repeating the ankle pump, and we can slightly elevate the foot end at least by 15 degrees to 25 degrees. Okay, angulation. Okay, the knee is not fully dropped. Okay, the foot should not be lying down. It's not called dependent position. That should be avoided. It should be slightly elevated, supported, and ankle pumps are very important. Okay, and once the patient is able to be stabilized and sit out of the bed without a monitoring, progressively we can increase the exercises. So this is the indication where, so this should be supported with HB level above 10. It should be supported with improving creatinine. Ideally, creatinine usually expected to come below 2 by this time, where you can increase the progression exercises. Renal biopsy should not show any acute renal ischemia or acute graft rejection. So if these things are satisfied, usually we can go for a progressive training. Suppose the renal biopsy is not done, then you can continue with mobilization, but resistance training we can wait. Resistance in terms of external resistance has to be weighted, but the own body weight or gravity as a resistance can be used, because already the patient is using his body that he has to use. Okay, so here the important thing is when you go for a progressive training, as I mentioned, the rating of perceived exertion should be monitored. It should be somewhere between 11 to 40. It can be going gradually up. Okay, this is the maximum limit. But in the immediate post-op period, we start from 6, it can go up to 11, and it can go up to 14. Okay, the peak heart exercises can be somewhere between 50% to 60% of predicted heart rate max. So heart rate max, we all know the simple formula you calculate. Even though the reliability is not so good, this is a general outline where you can use that as a guideline. As I mentioned, it has to be used along with RPE, heart rate, RPP, RPE. So these three should be combinedly taken into account along with pulse oximeter monitoring. Okay, so what we have seen is the hypertensive response, which, as I mentioned, which is commonly seen in more than 80% of patients, which gets plateaued with training. Okay, and it needs monitoring till it gets plateaued. This is very important. So this may take a few days or sometimes weeks. Some people, we are saying up to 2 weeks they had hypertensive response. Okay, so it is not that immediately they will get normalized response, but the non-linearity of the response is very important. Okay, what type of non-linearity response you're getting? If there is a failure to increase in BP or heart rate, we know that it's more dangerous than a non-linear increase in heart rate. So we have to use our general principles that has to be applied here for each and every day. Remember, day 1 they may do well, day 3 they may worsen, or vice versa. Okay, that has to be monitored. That's why I said it's a dynamic evaluation. Okay, so the 10RM is assessed. We all know that what is 10RM. 10RM is you ask the patient what is the maximum load a person is able to lift for 10 times, not more than that. Up to 10 times they are able to lift the maximum load. That is called 10RM. So in that we take 50%. So usually we come across most of the young renal transplant patient. We have seen that for upper limb, usually the 50% is half a kilogram, 400 grams to 600 grams, 500 grams is a usual thing. And for lower limb, it is up to 750 to 800 grams. Okay, so if you are possible, for every 100 grams you can progress. Okay, if not, we can go for half a kilograms, but usually we try to go for 100 grams of progression, starting from 500 grams. Gradually we can increase 100 grams of weight. Okay, so this all depends upon how the patient get habituated, and you assess the initial responses. That is very important. Okay, so going on to the second phase and the third phase. Okay, I'm combinedly presenting it for the need of understanding. Okay, we remember the phase 2 is up to 3 to 6 months, and phase 3 is beyond 6 months. The difference is in phase 2, the patient has periodic monitoring exercises, and phase 3, the patient has home-based training program and follow-up sessions on them. So only periodically, like every month once or every 3 months once, they come for progression of exercises and checking in. whether they are doing the exercises correctly. And you have to understand this phase 3 training is not fully established. Okay, it's still hypothetical. As I said, the follow-up is always a problem, but still we are trying to incorporate within 3 to 6 months, so that we want patient to get habituated with proper exercise intensity, which they can continue throughout the life. Okay, unless follow-up is there, we don't know how they are doing. That's why that's a gray area we have to develop. Okay, being said that, in phase 2 we are increasing the frequencies and duration. An important thing is the warm-up and cool-down, okay, which was initially 10 to 15 minutes, can be made to 10 minutes. Okay, minimum 5 minutes should be there, and 10 minutes could be an optimal timing in phase 2. And this should be along with some small stretches. And when you're doing stretching, make a care that the suture side stretch is also included, but it should be precautious. This is very important, because many times when you have a suture there, when there is a limited trunk mobility, we see many people develop partial deviation, and the lower lobe expansion is affected. So generally, to overcome this issue, whenever you want to go for a progressive training, the suture should also be, we know that it should be painless, non-adherent, and it should be pliable. So that to ensure that a gentle suture stretch can be initiated, and patient is introduced for a graded aerobic training. So in India, mostly the people are accustomed for walking or cycling. Their phase 2, we keep the heart rate. Okay, we said no, the heart rate max we keep it somewhere around 60 to 75%, and during the phase 3, that is after 3 months or 6 months, it should be from 75 to 90%. Okay, I think we have not seen much people who are able to achieve 90% of the maximum heart rate, mostly because of their fear, apprehension. Okay, and another thing is lack of monitoring system. They don't have anything to monitor. Even after 1 year, 2 year, they don't even cross 70% or 75%. Okay, that is a difference. So once the people are developing a particular setup for giving this training, definitely even our Indian patients can go for the Para Olympics, where the transplant people are also participating. The special Olympic programs, where unfortunately many times our people are not participating, are very meager in number. Okay, so heart rate and BP monitoring is periodically done in this period, and the patient has to be educated. The patient attendant has to be educated, and they have to be educated about the limitation of automatic BP recording system. At least the patient should be said how to palpate the pulse, how to palpate, how to what is the importance of pulse volume. These two things we have to tell: pulse rate and pulse volume. Okay, definitely they will not do as you as a professional can do, but still this particular simple knowledge will give them a lot of confidence. Okay, along with other monitoring devices. Okay, fine. So the another important thing is we have to add upon with important aspect here, the resistance training and the flexibility. The resistance training with free weights are progressively used in these people. This is very useful for these patients. So this resistance is gradually increased here. So from 50% to 65%, you can go up to 85%. And the usual, the progression rate is increased by 5 to 10% every week. 5 to 10% of progression every week is done. And important here is you can have 3 sets, and each set can have 10 to 25 repetition according to the tolerance of the patient. An important thing, you have to avoid the fistula hand. Okay, that's very, very important. Whenever you give resistance training, you cannot give a resistance training using the hand where fistula is present. But usually, once the patient condition improves, the fistula is removed. When the kidney functions are established, the fistula can be removed. If suppose the fistula is removed and reconstruction is done, yes, you can go for a resistance training, even that extremity also. Otherwise, we have to be avoiding. We can do aerobic type free exercises, but not a loaded exercises. Okay, we can use gravity and the own body weight, but not an external weight for that limb. Okay, and flexibility training is another important thing. So we see that nearly 80% of people have very poor flexibility because they are not involved in physically activity itself. Okay, they are not physically doing any activity, and flexibility is a big question mark. This flexibility is very important in order to overcome that fatigue, because when you have a good flexibility, you can do a good amount of stretching, which is an important part of your warm up and cool down. Okay, warm up and cool down is not just active muscle contraction. We know that it includes stretching. Only if they do a proper stretching and have good flexibility, they can do a good warm up and they can do a good recovery. So this will definitely improve on our exercise, and it also prevents the chances of muscle and ligament injuries, which is the main reason why people stop doing exercise. They after some time they get muscle pain, ligament pain, joint pain. This is because it's not because of the muscle activation alone. It is because of injury caused due to compromised flexibility. Okay, so that has to be done. So and whenever we know that this flexibility has to be hold. Okay, the holding time is important. Maybe we start from 5 seconds hold to gradually to 20 seconds. People say up to 15 seconds it's well and good. If possible, you can go to 20. Otherwise, an important thing, without breath holding. So this flexibility and stretching should be done without a breath holding, because these kidney patients already we know that their systolic BP is having hypertensive response. Okay, and you can increase it, or you can affect the cardiac output, putting more stress on the heart. To avoid it, the flexibility exercise is important. Trunk loading can be gradually done, but you have to avoid trunk bending till the sutures are completely healed and the sutures are becoming pliable. The important education, apart from monitoring of heart rate and BP regulation, muscle and cramps has to be informed to the people, and they should not get afraid. They should be educated. When you do exercises, you will get minimum muscle pain, because we know that no pain, no gain. But how much pain is there, how long is there, should be noted. Okay, so they are still educated to report any discomfort. In the phase 3, okay, it's mainly rely on RPE regulation, because we know that the phase 3 where the patient mostly going to do a unsupervised training program. So the patient should learn how to perceive properly RPE, rating of perceived exertion, so that they are always working in the safe limits. And also for cramps, and as I mentioned, scar mobilization is very important. After usually if it's a non-diabetic and well healed, for any patients, when the skin is healed and there is no oozing and it is not painful on touch, okay, or grade 1 touch, when you pressure there is no pain, you can go for scar mobilization. That's very important, so that you can have a good flexibility and good mobility. Being said, the phase 1 and phase 2, I'm just summarizing. Okay, the phase 1 training, as I said, which is physiotherapy is important, breathing exercises, parameter training, limb movements. Important here is we have to identify which areas of lungs are affected. We have to use proper positioning technique. We have to use the effort. Okay, inspiratory hold should be used, but the hold should not go more than 3 counts in the initial phase. The ambulation should be initiated according to the tolerance of the patient, and patient should be given the gravitational stress. So this is a very important thing. When every people are not able to get on their feet by even second day or third day, at least you should have a graded gravitational stress. That means getting the verticality from the lying position. Usually they are in a 45-degree position, coming to an erect position and maintaining at least in the bedside. This has lot of physiological benefits, giving confidence and gaining abilities of the patient. And limb leverage can be gradually increased. In phase 1, remember the RPE when you are using, progressively you can increase it from 6, that is very light, you can go to somewhat hard level. And the resistance can be added if the renal functions are improving, there is no acute renal rejection, renal failure. You can start with a resistance training of 50% of 10 RM. Okay, and the number of sets, usually it's a 3 sets, each one will contain 5 to 8 contractions. Phase 2, remember it's a inclusion of graded aerobic exercises in terms of walking. If treadmill is available, we are using treadmill setup, it is used. Or if people are more sedentary, and bicycle ergometer could be a suitable option. Suppose especially they have so much of drains and other things, bicycle ergometer, if you have a bedside cycle ergometer, it's a good option. It's an alternate option which you can use if the patient has an extended dialysis phases, because the renal recovery is still delayed. There could be something called delayed renal recovery. Okay, so in that cases, we may use a bedside cycle ergometer. We may avoid resistance training, but without resistance, the training can be continued. If the renal injury or acute renal rejection is not there, rested exercises are begin from 50 to 65% in progression. As I mentioned, 5% to 10%, you can increase the load every week. And flexibility exercises are important, especially generally the fistula is removed in phase 2. So flexibility training should not be an issue. And more you do a flexibility training, the patient exercise compliance is better because they have less chances for muscle and joint injuries. And remember, the RPE should gradually increase. It can go up to 9 to 12. So from 6 to 11, we can go from 9 to 12. Okay, you can start at a higher grade and go to a little higher limits. Okay, so the important thing is in phase 2, we are going to go for a progressive phase. This is a very important part in our renal rehabilitation or a post-operative training phase. We are talking after discharge, that is after 3 weeks usually, or we have seen people are getting discharged even by 2 weeks. So the duration is not important. Till they are getting discharged, we are got phase 1. In phase 2, the patient comes to hospital. Maybe they are called twice or thrice every week. This is important. They come for physician review. Okay, another important thing I emphasize in this particular protocol is it's important to implement in our hospital setup, Indian setup, where after 6 months the follow-up is sporadic for the patient. Whereas first 3 months the patient comes regularly to the hospital to see the physician and the surgeon. Okay, so that is a wonderful opportunity where we can optimize that ability. So that's what we try to make use of it. So at least minimum 2, they come 3 or 4 times, at least 2 visits supervised training they are given, and other 2 or 3 sessions they do at home. And weekly progression is again made. We progress 60 to 70% or 75% of heart rate max. RP is going up to 11 to 14, and the duration is increased. Okay, usually we say that to start with, we give a 10 to 15 minutes session 3 times a day. Then we make it 20 minutes 2 times a day. And later in phase 2, we make it 2 sessions if possible. Otherwise, 1 session of 45 minutes or 2 sessions of 20 to 30 minutes. If you can do 2 sessions of 20 to 30 minutes, it's well and good. Otherwise, at least 1 session of 40 minutes. Okay, apart from your warm up and cool down. That means the patient has to spend nearly 40 minutes to 1 hour, 60 minutes for the training program. Maybe initially the patient are not very recipient for about it, but as you train and they see the benefits, they are very well able to cope up. The load can be increased at the rate of 5%, and some patients who are young and energetic can go up to 10%. In all cases, we have to indicate, we have to be very careful, muscle soreness and overtraining. Okay, and also you include small loads in functional activities. This is what I want to emphasize in Indian scenario. Most of our family members know in the follow-up we see that even patient has the ability, they are not given an opportunity. They do only exercise, they don't do any other activity. So that should not be the case. We have to encourage the family members to support the patient, be beside them, allow them to do some activities without loading the suture area. So taking the precaution, still they can participate. And patient education and follow-up are very vital. As I mentioned again and again, we have to strengthen our area in patient education and mainly the follow-up. Because in phase 3, which I mentioned, it is going to be a home-based increase in activities, and it is a self-paced walking, which is tolerated by the patient. And whenever the patient comes for follow-up, we ask the patient to monitor their improvement, monitor their exercise activities. So this is in the follow-up what we'll see, and that is reviewed. And based on that, you advise the patient, okay, or you have done so much of exercises, this is the heart rate change you have attained. So still you have a reserve of so many beats. So in terms of heart rate or in terms of perceived exertion, we ask the patient to progress. So when you give that guidelines, the patient will keep improving their ability. Otherwise, what will happen? They will do the same 20 to 30 minutes of walk till they die. Okay, or they will walk in the same speed till they die. Okay, so that may not. So we know that exercises by definition, it should have the component of progression in load. It should have a structure, and it should have set goals. And according to the goal, your activity should be modified and it should be mainly progressed and changed. And we have to overcome the boredom. Either you can change the frequency, mode, okay, and exercises should be changed. And you can try to incorporate wherever possible the physical activity induced exercise effort. That's very important. That we can do in the follow-up period. If the patient is not physically seen, at least phone call reminders or phone call review is important. Okay, and the progression can go up to 14, but usually for if you're not thinking the patient to go for Olympics, okay, RP up to 14 is permitted. If you think the patient is young and energetic, okay, in Western population they say we can go up to 16. to 17, which is the highest level where you think you want the person to become a sports person, a competitive athletic activity if they are involved. So there you can go, but not for all patients. So we are very happy, and the good health status can be maintained if the patient can do exercises in a periodic interval, which is usually 3 to 4 days minimum per week. But as people, most of them are diabetic and hypertensive, they need to do some exercises every day. They have to just do 7 days per week. Okay, you have to tell them, you have to encourage the patient. It's difficult, but they have to make it as a routine. And for follow-up of these exercises, there are different activities undertaken. We have to maintain exercise log with the patient and the caretaker, and the caretaker should give the endorsement. That's very important, because even when you go for research or anything, without the endorsement of the people, the attender or a third person, it's not valid. Okay, so it has to be done, and every time it has to be noted, and it should be updated in your records. Phone call reminders are a valuable thing, but many times patient after 3 months they don't pick up your call. Okay, so that depends upon how much rapport you have developed. Okay, and WhatsApp groups is one of the valuable thing. So some of the studies have been done where WhatsApp groups they are created, and we all know that as we are having so many discussions, the data are transmitted through WhatsApp or any other online platform, social medias are available. There you can use. And Google Fit app, which is recognized thing by WHO, can be incorporated. If the patient has a smartphone, the particular data can be sent, the physical activity monitoring can be sent to us, and we can guide, we can set heart rate, which is recommended by WHO. Okay, we all know that 10,000 steps per day is recommended. Okay, and sometimes these people require to do more than that, especially if they are going to be young people. Okay, so these wide information has to be disseminated, and it should be followed up. So without follow up of these data, definitely the patient, we are going to land them into poor cardiovascular condition. They are prone for cancer. We know that cardiovascular disease, cancer, okay, new onset diabetes mellitus, obesity, sarcopenia, bone mineral density disease. So all those things are amenable when you do exercises with good medications and dietary advice. So all are important, but exercises is usually difficult because diet to some extent patient are possible, and most of the dietary restrictions are removed. Actually, if there is a successful renal transplantation, the patient is allowed to eat everything. So it is something like a stress relaxation. Okay, so before surgery, when they are on dialysis, so many restrictions, sodium, etc., diet restrictions are there, protein restriction is there. But once the graft functions are established, okay, you can see a drastic change in the patient attitude. They eat everything because there is no diet restriction. But we have to educate them. Still, they have to moderate the diet. They have become normal person, well and good, but they have to keep the healthy status of their kidney and the body system. And the difficult part is the exercise. We all know that exercise, we also, when we start exercises, we discontinue within few days. So without a follow, without a continuous guidance, it is not possible. And as we have become successful in the immediate post-operative care, I think we have to have a good rehabilitation setup so that we can have a proper follow-up. So the simple precaution that we have to take in a phase 3 is we have to make a tailor-made assessment. Okay, phase 3 is very important phase because each patient is going to progress in different way. So we have to make an individual assessment of patient, and as physiotherapists, we have to communicate for people who are giving a reference, or we have to communicate with the patient individually to make it clear that this is an exercise prescription for you. If there is any modification, it should be modified after re-evaluation. Make it clear so that they understand it is not an easy way. So we know that exercise is referred now as medicine. So as medicine is prescribed, exercise should also be prescribed and followed. That should be made clear in the patient mind. It's not a easy thing to take it and do it or leave it to do. Okay. Next thing is they have to involve in a good exercises, but same time the vigorous activities involving weightlifting, bending is individually assessed. What is the healing status? Okay. What is the kidney function? What is the abdominal circumference? So those things are checked from phase 2 onwards. Then it is started. It should not be widely started in the early stage because patient is doing well. So we have to wait and do it. Avoid exercises immediately after food. So this is a very simple thing, 20 to 30 minutes. But many times we hear from patient that they after the night dinner they go for immediate walk for 20 minutes. Okay, we have to advise them. So you are doing exercise is a good thing, but timing of exercise is important. Okay, so studies have shown that 5 to 8 or 5 to 7:30 a.m. or p.m. is a good time for exercise, because this is a time where your glycemic monitoring or glycemic indices are maintained better. So that's an ideal time. So we have to select an ideal time, ideal environment, including the food intake. So if they have taken food, ask them to wait for 20 to 30 minutes. Better post dinner, maybe they can do some mobility, but that should not be like an exercise, which is the overloaded one. That should not be done. Okay, if they are doing in the daytime, so we know that 20 to 30 minutes of rest will help in a digestive process to take up its role, and then we can do the exercise. Okay, and whenever another important thing, we have seen few people developing suture complication, because in phase 1 we are there, we are supporting. In phase 2, when they go back, some people may have a delayed suture dehiscence, okay, because they have not properly supported while coughing or doing activity. So avoid any corsets unless there is a visible damage. Corsets are not advisable, because we know that it can go for general deconditioning. So whenever they are going for coughing, ask them to support it properly. That should be followed not only for immediate post-op, at least for 6 to 8 weeks time for a diabetic people who had a delayed healing status. Always you encourage the patient that they have to respect your breathing effort and continue with any exercises. Okay, the simple thing is walk and talk test. We all know that. Okay, the person should be able to comfortably talk and communicate to the neighbor person when they are walking. Okay, apart from monitoring the pulse, BP, one simple thing, walk and talk test. Okay, they should be able to comfortably talk and communicate their problems to the next person. So that is a simple way of putting it for the patient, but that is not an ideal way. Okay, and whenever the patient has any symptom, especially giddiness or breathing, ask the patient to stop immediately. If possible, sit down. Okay, there is no chair, then you teach them how safely put their hands on the sides, come to lying position, sit down, and keep doing ankle movements. Okay, don't stop if they are doing a moderate level of exercises. If they feel some problem, when they sit down, ask them wherever possible, do a deep breathing and do some ankle. So you have to teach them also some coping strategies, so that will give them some confidence how to do exercises even in unsupervised setting. But we are expecting that people should come for a supervised session so that it can be progressively done in an optimum manner. Otherwise, people will be doing underloaded or overtraining. So that should be avoided. Being said that, okay, so I just want to share few experiences in our place where we had the structured protocol we have developed, and we have tested on some group of patients, about 100 people. Okay, 15 each group, control and experimental. And in that study group where we have given structured training program and given a follow-up advices, follow-up care was given, we found out that the functional capacity measured by 6-minute walk distance was statistically significant, and clinically the patients were very effective in their performance, participation in activities. The quality of life domain improved in all the domains, physical domain, okay, physical limitations due to role limitation, sorry, physical health due to role limitation, energy level, fatigue level, general health. In all the domains, they had a significant improvement. Similarly, the quadriceps muscle strength, which was assessed, okay, so they had a significant improvement. You can see that the study group had a very peak increase, especially after the 6 weeks training. Okay, and up to 12 weeks, we had a follow-up of these people, and beyond that, the patients are informally contacted, and we are getting positive feedback, but it needs to be studied and analyzed. It's not done. So fatigue score is also drastically decreasing. Important thing, you can see that the point of decrease is very drastic with the study group. The blue color thing indicates the study group where we have applied this protocol of training. Okay, to summarize, okay, so as we have seen in our experience in our center in Ramchandra, similarly we have got a similar results across the world. Painter et al. Is one of the leading researcher in this area, where the cardiorespiratory fitness, quadriceps strength, body mass composition, and quality of life all have improved, similar to our findings. And there are few studies indicating autonomic functions also improving, and this needs a training period of more than 12 weeks. Okay, so in that case, autonomic function. That's why I'm emphasizing that phase 2 and phase 3 training needs to be strengthened in India. In a country like India, where we are not affordable to lose people dying with a functional graft, where functional graft is not available. Moreover, to have a better quality of life, we have to get these benefits. Supervised training improves the muscle strength. So we have an ample of evidences to say that resistance training, this resistance training is going to increase the overall overall abilities of the person. Resistance training, like we have an high intensity, low intensity training, according to the patient age and abilities, we can prescribe them. There's a significant benefits with the early intervention. This is what we have developed this particular protocol where we are starting intervening the patient by second week and third week itself. Because as I mentioned before, we have a poor system of follow-up, because even we want to see patient once they become independent, patients have a hesitance to come. So that knowledge, and also they have to cover with the insurance system. So when these things are getting established, the social systems are established. Okay, the social system or insurance will cover once you have a proper evidence. So that's why we are creating research evidence to say that the physiotherapy, not only in Western where they use modern gadgets, with the simple exercises also, we are able to get a similar benefits. That's what important for our country, like a developing country. Okay, so finally, I want to say the word that there is a need for a structured and early exercise training program, and importantly, the follow-up should be there, and it has become affordable to meet the growing demands, because we know that the number of transplant is going to increase further. Okay, and we are going to have a more population, and we don't want these people to die with a graft, functional graft, and to have a better quality of life. The exercises should be sustained. Okay, so I conclude the session with saying that the structured exercise training protocol in a renal transplantation is the need of the hour, and it is safe and it can be effectively used, and there is a need to establish a structured program. Okay, as per the clinical scenario, this is very important in your area of practice. Okay, so maybe it may even vary slightly from a hospital setup to hospital, but we need to have some form of structured training program where all the team members, so we have to work as a team. Okay, it's not like only exercise, diet, psychologist, okay, the counseling by them, and medical people and surgical people to know about the techniques, what they have changed in surgery. So it should be a collaborative team approach too, and it is not only for the immediate post-op period, 2 to 3 weeks. It should be beyond it. It should extend beyond it. Okay, as they come for a medical consultation, surgical consultation, patients should be educated that they should come regularly for physiotherapy also. Okay, as I said, for first 3 months, they can make at least 2 sessions per week, where they are coming 4 times to see the doctors, physicians. 2 times they can come to physiotherapists. At least once, something will be better than good, nothing. Okay, and after 6 months, they come monthly follow-up. So that monthly follow-up, at least half an hour they have to spend. They have to learn what is new. So that has to be impact. That impact has to be created in the phase 1. That's where our success lies. Okay, and we have to develop the strategies to how to sustain the benefits of initial post-operative period. And our future focus is to reduce the risk of cardiovascular disease in the renal transplantation patient. They are developing cancer. We don't want that to happen, and early graft loss has to be prevented. So keeping that as our long-term benefit that we have to sustain for patients, we need to have the structured training protocol, which has to be introduced, which has to be accommodated and adapted by the patient from the early phase. Okay, so I think with this I'll concluding, and these are the basic references for this particular presentation. I thank the organizers for giving this wonderful opportunity. I'll be happy to take up any discussions further.
Thank you so much, sir. First of all, I thank for your hard work behind it. It was a lengthy session, and you explained everything in detail. Even BPT students who are present here will know what to do. This is not only for renal transplantation. Many of things are post-operative, so they might have got a lot of ideas from your session. And second of all, thanks is I thank you so much for having our webinar Super League ExRxIndia name in your presentation. We are happy about it, sir. And we will take questions, sir, now.
Yes,
Rupesh, I was disconnected. There are some questions in chat box.
Yes, sir.
Please read it.
Can I read it out, sir?
Yes, please.
Yeah, first one is from Mr. Shankar Ganesh, sir. When during mobilization of transplant, patient complains of pain in the gluteal region. If it is claudication pain, then how I can progress exercise, sir?
Yes. Okay, thank you, Shankar Ganesh, for that question. I think this is one of the experience, as I was mentioning, which we have seen nearly about 10 to 15% of patients. It's the gluteal pain, or it could be an anterior thigh pain. So in that cases, as I mentioned, the initial screening is important. The first thing that we have to check is the abdominal circumference. Any abnormal increase of more than 4 centimeters on the previous day, usually 4 to 5 centimeters. In that case, we have to delay your ambulation. Unless you reassess the patient, you cannot re-ambulate. Second thing, how much time you made the patient to sit erect. So suppose the day 2 patient is doing well, suddenly you take him to standing. There, as I mentioned, there have been inflammatory fluid collected in the abdominal area. It's a post-operative change with the drains. Okay, and that could be compressing the nerve or irritating the nerve roots. So the amount of stretch that is lying on the nerve roots will be more. So to accommodate the nerves for a stretch, you have to change the position in a gradual manner. That's why I said before you make the patient or mobilize the patient out of the bed, you have to make the patient to sit and see for the responses. Give the bedside exercises initially, and then you have to go for the gluteal. If the patient still persists to have it, then you have to go for the gentle stretching exercises, or when you have a gluteal, the antagonistic group, that is your quadriceps, you have to check the strength. If it is not having enough strength to execute it, that has to be developed using isometric techniques. So once you do that, then probably you can go for progression. Okay, so first thing you check for the abdominal circumference and its increase. Second thing, gradual progression in the change of posture. Third thing, warming up of the muscles before doing the mobility. Probably if you do these 3 things, you should be able to gradually mobilize the patient. That is one of the important things that you have to note down in the immediate post-op period.
Fine, sir. Next one is from Mr. Vishwanath Padvashetty. How to treat restless leg syndrome, which is common complication in renal failure patients, sir?
Okay. Okay. Thank you, Vishwanath. Actually, we are now discussing about renal transplant, post-transplantation, but he is asking a question in a CKD people where they will have a restless leg syndrome. So restless leg syndrome is one of the painful condition we come across, and as a physiotherapist, we have some role in terms of exercises. But before going for the exercise, we have to rule out the medical limitations. Okay, as I mentioned, first thing you have to check for CKD is your electrolyte imbalance. Okay, if the patient is going to have a low sodium, okay, and they have a low potassium, in these instances, which can induce your muscular fasciculation, fibrillations, that could lead to cramps, and that can be one of the reasons. So you make sure the electrolyte imbalance is corrected. Second thing is renal anemia. As I mentioned, most of the CKD patients will have a renal anemia. In that case, the anemic status should change, and usually that will be the area where we can work a lot. That is simple ankle toe movements, and we have even learned about some of the Berger exercises. Okay, so if the patient is not having any cardiovascular instability, we can give them Berger exercises. And important thing, the ankle toe movements and regular change of posture is very important. But this is again based on the renal anemia, the extent to what it is present. The third important thing that you have to see is, we mentioned electrolyte and renal anemia. The third thing is the neuritis, the diabetic neuritis. So again, for a diabetic neuritis, we know that you have to see for the HbA1c level. When the HbA1c level is more than 8 or 8.5, again we know that it's an uncontrolled diabetes. Okay, so along with the medical supplementation, we have to again concentrate on aerobic training, and we have a good methods like warm or contrast bath methods. So you have to take care of sensory evaluation. So once the sensory evaluation is done, you have screened, the thermal sensitivity is intact, then you can go for a contrast bath followed by ankle pumps, then go for mobilization of aerobic exercises. So depending upon the underlying cause, we have to treat the underlying cause and gradually incorporate our ankle pumps, change of positioning, Berger exercises, and aerobic exercises in terms of walking and cycling can be done.
Fine, sir. Next question is from again Shankar Ganesh, sir. In acute phase, which POD I have to start resistance exercise and what precautions I have to take, sir?
Yes. Okay. So resistance training is one of the important area we are focused in this particular discussion. But we have to understand, as I mentioned, the three criteria that we have to look at. One is the vital stability. Second thing is the patient should not have any renal rejection. Okay, or patient should not have any signs of acute renal failure. Okay, so if there is a delayed recovery, which is shown by burn and creatinine, when the burn comes to the around 2 value, probably that could be one indication that you can start resistance training. It doesn't matter what POD. Okay, so as I mentioned, POD is only for the guidelines, but POD cannot be taken in actual sense. Okay, so usually we are able to start resistance training by 4th or 5th day, wherein all these parameters are settling down. In some cases where they take up to 10 days to these renal parameters to settle down, we have to delay till 10 days. Till then, we can give gravitational stress, the own body weight, the leverage principle I was mentioning, that can be given from day 2. Okay, but I'm talking about the external loading that can be done only when you rule out the renal ischemic status, the burn creatinines, especially creatinine comes around 2 value, then probably you can go. And another important thing, once you do a resistance training, it's very important. Next day you have to see for the follow-up assessment of your burn and creatinine. If you are noticing that there is a sudden shooting up of creatinine or burn, I think that means you have done too much. Okay, so we have to admit that limitation also. So the amount of exercise that you are giving should not increase the burn and creatinine level next day. Okay, so it is not on the POD. We have to see for the renal ischemic threshold is not there. The renal is not, the kidney is not in ischemic state. Okay, there is no any delayed signs of recovery, and burn creatinines are coming within the normal limits. At that time, you can start external resistance. Otherwise, you can go for a gravity or limb leverage based resistance.
Yes, sir. Next question is from Mr. Ajit Kumar. Can the rehab improves the erythropoietin balance and improves the erythropoiesis? So can the renal anemia be prevented or compensated, sir?
Yes, that's what we are trying to achieve. And one thing we have to understand from the medical point of view, we are not only focusing from the medical point of view after the surgery. Okay, up to 6 to 8 weeks minimum, these people are given with erythropoietin injection initially. Okay, but after when you start doing the exercises, you can sustain it better. So initial POD, we want to have a good RBC level, good graft healing. So it is taken care medically, but we are talking about our role becomes important after 3 months, where these medication effects cease off. Then it depends upon the body's natural ability. So definitely we have a role, and that is why I'm emphasizing even after 3 months, our exercises should be done in a progressive manner, which is sadly not happening. After that, the exercise intensity comes down for the outbreak. That's what we have observed in our patient group. Okay, that's why I'm emphasizing that after 3 months, you should have a progression, and patient should come for a supervised training at least once in a week. Definitely, exercises will improve erythropoiesis.
Fine, sir. Next one is from Miss Aishwarya Sriram. When we are performing the 6 minutes walk test, how do we differentiate whether we are measuring accurate VO2 max and VO2 peak, sir? Are we measuring VO2 max or VO2 peak with this test, and is it accurate?
Yes, this is again a important thing. That is when you do a 6-minute walk test. Okay, so we have to understand it is a self-paced test. Okay, patient is doing at his own pace, and we are not, what you are trying to measure is not VO2 max. Many times it's a misnomer we are taking. Many places it is used VO2 max, but actually what we are trying to measure is VO2 peak. VO2 peak is what is the maximum ability a person can reach. VO2 max covers the entire curve under the exercise timing. Okay, so exercise peak, we are measuring VO2 peak, and we have challenge formula where you can apply it, and we can accurately measure the VO2 peak. Okay, to what accuracy we are getting it, that depends upon the patient effort. That's why we say it is a patient effort dependent. The patient should be well motivated, the instructions and the environment should be maintained as per the ATS guidelines. Once you do that, we can ensure that what we are measuring is VO2 peak, and we are trying to equate to VO2 max, because there is a relationship, positive correlation between VO2 peak and VO2 max. So we are trying to correlate, but we have to understand 6-minute walk test gives only VO2 peak, not VO2 max.
Yes, sir.
VO2 max can be assessed by the metabolic card, where we have gas analyzer. That only we can give you the exact VO2max.
Yes, sir. Next one is from Mr. Abhishek. What intensity of exercise, according to FITT principle, can we start with in a patient who has renal anemia?
Okay, so renal anemia in what stage is important? Okay, so in the question they are asking fit. Okay, so fit, because CKD is a broad spectrum. We have from stage 1 to stage 5. Okay, so we have to see in which stage they are, but which, and depending upon the severity of the renal dysfunction, we can incorporate the intensity of training. So at any stage, what is recommended is aerobic, and the aerobic training should be starting minimum of 20 to 30 minutes, minimum of 5 days per week. Start from 10 minutes to 30 minutes, and the intensity should be heart rate. As I said, you can go from 40% to the maximum of 60%. Okay, and this has to be done in progression. But as I mentioned, it's important to know the associated comorbidities, because renal anemia is one of the effect of chronic kidney disease. We have to see the stage, how many dialysis they are getting, whether they are already on erythropoietin injection, whether they have adequate caloric intake, and what is the electrolyte balance. Based on that, you can decide the intensity. It can vary from as low as 40%, can go up to 60%. 5 days a week minimum. Starting from 10 minutes, you have to go for ideally 30 minutes, but we have to start from 10 minutes.
Yes, sir. Next question is from Ms. Disha Jagat. Is there any role of prehabilitation in live donors before donating the kidneys as we do it for the transplant patients, sir?
Yes, definitely prehabilitation definitely has a role, but the only question is if it's a live transplantation and patient is getting referral. But usually, as I mentioned in my presentation, we get referral only when the patient has any specific issues, when they have chest complication. No, that time only they are referring. If the patients are referred to us, we can increase their abilities. So, and again in the question, can you make it clear? Is it for donors they are asking or for recipients? Rehabilitation for donors or recipients?
For the donors only, sir. I'll unmute.
Yeah, unmute and make the
Sure.
question clear, please.
Disha Jagat, you can unmute yourself.
Yeah, sir. I had asked for the donors specifically. So, can we give rehabilitation in donors?
Yes, that's one of the important area that needs to be explored. But right now, donors are selected only when they have a particular physical activity and a medical status, right? So when they are already in their optimum level, okay, that is the guidelines. According to the guidelines, if they take the donors, they should be having a good physical activity level capacity. They should not have any comorbidities. Okay, okay. If they have comorbidity, it should be controlled. So based on the guidelines, when they take, usually they are not referred. Okay, and because of surgical technology, okay, they are able to do a microscopic or laparoscopic excision of the kidney, so the post-operative stay is also very short. Okay, so only in case of complication they are referring. Definitely the prehabilitation has a role, but it needs explored. I think very few studies are available on prehabilitation of the recipient itself. So in that case, donors, I think it's an area which need to explore. It's a good question, but again, if you go by guidelines, they are already healthy. So the question of why you have to give will come. So if you have a proper justification, definitely if they have an issue, they can be addressed. Rehabilitation might have a role for a people with some risk. They are taken in for a donation. For them, it will be required, but it needs to be explored. It's an area to be explored.
Fine, sir. Next question is from Mr. Ajit Kumar. Precautions needed for the DVT, PVD for the very often complaints like cough pain. What can be done, sir? Especially people undergone RD.
After renal transplantation.
Yeah.
Okay, so after renal transplantation, when you get these complaints, so as I mentioned, kidney, when they are taking a renal transplantation, they are put on a lot of medications. As I mentioned before, when you have to see what type of medication they are taking, like tacrolimus. Okay, so certain group of medication which are nephrotoxic or hepatotoxic is there. So when they have hepatotoxicity, they will usually monitor the INR levels. Okay, in spite of monitoring the INR levels, sometimes they are not under control. So the first thing we have to look for the INR levels in a post-transplant patient who has these complaints. Okay, so how to prevent it? So obviously the physical activity level will have a role, but again it can be a medically induced one also. Okay, so that should be handled case to case. So we have to first rule out the medical induced DVT is there, whether the patient's INR values are stable. To prevent it, if you ask, right from the beginning, you need to do a aerobic type of exercises. And as I mentioned, the ankle pump, we know that the calf is your second heart, so that has to be activated as frequently as possible. That's the only best way to prevent it, apart from your medical care.
Fine, sir. The next question is from this is your student from 2010-2011 batch. Your class is still the same grade with extensive of information, sir. Thank
Not
you.
boring. Hope it's not boring.
Yeah. Thank you for sharing your knowledge on not much explored topic. Extremely happy to have attended your lecture after years, sir. It is from Miss Janani Ravi, sir.
Okay. Thank you, Janani Ravi. I hope you are also doing good. You've done some webinars. I have seen that. It was very nice.
Any questions, dear participants?
Yes, sir. Janani Ravi took 2 or 3 sessions for us, sir, actually. Very wonderful sessions.
Yes, yes. I have seen 2. I have seen 2.
Thank you, sir. Thank you, sir.
Thank you.
Any other questions, participants, please?
No, sir, not yet. And many appreciations actually in between.
Yes, sir. There are many appreciations, sir. We will
sir.
send the feedbacks to you. And I would like to thank Dr. Shankar Ganesh especially. He only suggested me to talk to you and have a webinar on this topic especially. I thank Dr. Shankar Ganesh during this time. And I thank Dr. SENTHIL Kumar sir for a very much informative session about renal physiotherapy after renal transplantation. I thank all the participants and I thank ExRx team members, Dr. Rupesh and Professor Tuna Saha for their help the whole day today actually without getting tired.
Yes.
And I thank everyone, sir. I thank everyone. I thank you. Thank you so much, sir. We are happy to learn from you.
Thank you for the given opportunity. Before concluding, I also extend my sincere thanks to all your team members. Okay, and especially Chandramohan sir, we have taken a lot of efforts. I know he's quite busy. Okay, I think he's apart from his clinical other routine work, he's doing this. It's a wonderful job, and I was very happy to see that now we are taking the student-to-student webinar also. It's one of the interesting, and I heard from many students that they were very much active, become very dynamic. Because they wanted to do that. No? That you are creating that awareness and enthusiasm in the student community. It's a good thing. I hope it's a long way to go and you do well. And at the other end, I also thank my management who accepted and allowed me to present it. Our principal Shivakumar sir, our chairman Venkatesh sir, and vice principal Anthony Leo sir, and our dean, okay, who readily accepted and permitted me to do it and share my piece of knowledge with you. Okay, and it's a learning experience being with you all. And I got very good questions from the students and the participants. I am very grateful to the whole organizers and all the participants. Thank you so much.
Thank you, sir. I extend my regards and thanks to Dr. Shivakumar sir and all who helped you to present this webinar. Thank you, sir. Thank you so much. Good night, sir. Good night, Rupesh. Good night, Tuna madam.
Thank you. Okay.
Bye-bye all.
Thank you, sir. Bye.